Good morning, everyone. Welcome to the Oregon Older Adult Behavioral Health Initiative 2023 Geriatric Competency series. Today, we're training on the neurobiology of addiction with Dr. Jordan Blacktop. A couple of training etiquette and CEU details. Please mute your mic. Utilize chat for questions and comments. Feel free to introduce yourself in chat. Slides will be available to you. Live attendance is required to receive CEUs. To claim CEUs for today's training, you must complete the Oregon NASW CEU survey. To receive a certificate of attendance, please complete PSU survey about today's training, what you learned, topics of interest, how we are doing, suggestions and comments. You will receive a follow-up email with links to surveys and other training materials. The Behavioral Health Initiative was created for older adults and people with disabilities. It was launched in 2015 to meet the needs of older adults and people with disabilities by improving timely access to care from qualified providers who work together and provide coordinated, quality, and culturally responsive behavioral health and wellness services. Specialists engage in collaboration and coordination in the systems of care. We help build knowledge capacity through free workforce development trainings and community education. We also provide complex care consultation. The Oregon Older Adult Behavioral Health Initiative is funded by the Oregon Health Authority and supports 24 specialists statewide. Next month, we are not having our training. We have symposiums going on, but we encourage you all to register for the National Council on Aging's 6th Annual Older Adult Mental Health Awareness Day Symposium. I will put a link to that registration in the chat, but I would please join me in welcoming Dr. Jordan Blacktop. He is a coach, educator, and scientist. He is the founder and owner of Solscience. His past experience includes working at Coos Health and Wellness as a QMHP and mental health specialist, as well as an assistant professor at Oregon Institute of Technology. He has been a postdoctoral research fellow at Washington State University at the Department of Integrated Physiology and Neuroscience from 2013 to 2019. He was a graduate assistant and earned his PhD in biology and neuroscience from Marquette University. He also has a BS in biopsychology from Marquette University. Dr. Blacktop has engaged in the investigation, mentorship, and teaching of broad scientific palette, which includes systems of biology applications towards understanding wholeness. His areas of expertise include the integration of biology, neuroscience, psychology, physiology, anatomy, behavioral health, and different coaching modalities to assist others in finding their path to wholeness. Please join me in welcoming Dr. Jordan Blacktop as we learn and gain a different perspective about addiction, why it can be difficult to treat, and the effects of drug-induced neuroplasticity. Thank you, Dr. Blacktop, for joining us today.
And Dr. Blacktop, you are muted still, just to let you know.
All right, how about now? Are we good?
Mm-hmm. Yes.
Okay, good. Can you see my PowerPoint? Angela?
No, not yet.
No? Okay. How about now?
Yes, you're all good.
Fantastic. Thank you so much for the warm introduction. It's an honor to be here. I see some names that I recognize at Coos Health and Wellness, and I've been on an Oregon tour. Now I'm heading back to the Midwest to be with family and kind of continue along my evolution. And today we're going to discuss what I've been studying for the majority of my adulthood, which is the neurobiology of addiction specifically. And it's an honor to be partnering up with the Oregon Older Adult Behavioral Health Initiative. And today we're just going to take a look and start kind of peeling back a few different layers. And we have quite a bit of ground to cover just to kind of give you a global arching perspective and integrated holistic approach. But we're going to start out with kind of the academic version, and then we're going to kind of go into more of the progressive integrated holistic approach as I kind of have gone on in my path as well. If there's any specific questions, we can either wait for, if they're pressing, I'd be happy to answer them, just make them available during the presentation, or, at the end, we can have more of a roundtable Q&A, which I think is typically the format. Is that correct, Angela? Okay, fantastic. So again, huge shout out to Oregon Adult Behavioral Health Initiative within Coos, Curry, Jackson, and Josephine counties. Go ahead and see what they're offering up for you at oregonbhi.org. And again, this is coming out of the Solscience LLC, and you can get further resources at solscience.org for the coaching, education, and scientific approaches. So for today, we're going to discuss the disease model of addiction, kind of going beyond viewing addiction as impulse control problems, but really looking at how it can transition from impulsivity to compulsivity. We'll look at stress and trauma. That's an underlying root of addictions. We'll look at different therapeutics, and we'll also tie this into the older adult behavioral population. We have a lot of baby boomers coming into that realm at this time, and they like to have fun, didn't they? So I know my father did. Okay. So we're going to discuss a few different things. Specifically, the objectives for today are going to be, why is substance use disorder a disease? What are the causes of substance use disorder? What is drug-induced neuroplasticity? Why is substance use disorder hard to treat? And what are some alternative approaches to treating substance use disorder? Because we're kind of at that point where we're all trying to become more trauma-informed. We're all trying to understand how things work. We went through the COVID snafu for the last few years. How do we get some traction and move forward in a progressive way to get back on track? So this is the section looking at the disease model of addiction. Why is it a disease? Disease. Typically, we think about it being an unhealthy illness or sickness. Dis-ease, to have a lack of ease or comfort, is another approach of looking at it. The disease model of it is really looking at the effects of drugs on the brain and how the brain works with drugs, how the drugs change the brain, and how changes of the brain control behavior. This is what I had studied in graduate school and undergraduate as well. But this is only part of the story. And when we get to that point, I'll start discussing that sometimes it's the chicken before the egg, or the egg before the chicken, when it really comes to the effects of drugs on the brain and how that controls operant behavior. So what is substance use disorder itself? A lot of you know that it's a chronic relapsing dis-ease of the brain characterized by loss of control of substance intake. So I'll use drug and substance interchangeably. I'm trying to transition into substance, and we'll discuss why in just a few moments. Decreased drive for natural rewards at the expense. So the natural rewards are at the expense of the substance. And even following prolonged periods of abstinence, you can get a situation where you're still at high relapse vulnerability. Even following periods of prolonged abstinence, years even. Philip Seymour Hoffman, one of my favorite actors, for example, if you do not, when we'll talk about tolerance and withdrawal and going back to the vulnerability of relapse and triggers. So the DSM-5, following the DSM-4, they kind of did more of an integrative approach oriented around craving, where you have a recurrent substance use causing significant clinical or functional impairment. And it depends on the severity, so you can classify that as mild, moderate, or severe. And when I was in graduate school, it seems like that was a while ago, so I'm imagining the DSM-6 around the corner, if it's not already being made. I'm sure it is. But they combine the DSM-4 abuse and dependence categories into one substance use disorder and replace legal problems with craving, because craving was a hallmark of substance use disorder. And you can still get in trouble with the law and not necessarily have cravings. So they really went more for a physiological disease-oriented classification. And substance use disorder is relapsing, meaning that it has the same relapse rates as other diseases of the body, such as type 1 diabetes, hypertension, and asthma. But what's really happening at the neurological level? What is happening in the brain that we can say it is a disease? And exactly what is facilitating this process? Well, we can say it's relapsing, but that's only a percentage. And we all know that you can say whatever you want with statistics. So let's be clear about what we are looking at here. One of the things I always like to do is reduce stigmatization and harm while affirming dignity, compassionate inquiry. So we want to avoid stigmatizing terms. Substance use disorder instead of addiction. Why? To avoid referring someone as an addict. Addict is very stigmatizing and induces shame. Puts them in a label and a box. Triggering terms. Substance instead of drugs. Why? Drugs can induce craving. If you say drugs and they associate the word drug with a high, that in itself facilitate craving and facilitate relapse as a result. So substance use disorder is very cyclic. You start out by using a drug to feel euphoria, to feel good. Over periods of time and repeated use, you start to get withdrawal, dysphoria, the effects opposite of the drug. Then you get craving, and you chase that euphoria again, and it becomes a cyclic aspect. And this slowly is like a hurricane that starts out really small, kind of innocuous, under the radar, and it builds steam over time until it becomes almost from one of those tour-to-world type miniature things you see in your lawn to a full-fledged hurricane with its own name coming in on the Atlantic type scenario. So what drives substance use disorder? And we're going to get to this as we kind of go into the more integrative, holistic aspect, but from the substance use disorder as a disease, what's driving it? We have no ability to necessarily pick one cause, because everything is integrated in a holistic, meaning you have genetics, you have the effects of the substance or the drug, you have the environment. So really, what are you dealing with? Susceptibility, transgenerational, mental and physical comorbidities. We'll see that. A lot of the use stems around self-medication. You have using the substance to feel good, avoid the negative effects of withdrawal, and the effects of the drug on the brain. And we're going to go really far into substance-induced neuroplasticity and look at how the brain changes. Also, the environment, cues. We talked about cues such as the word drug, context. When someone is in an environment in which they used to use before, and then they're more likely to get craving, and those cues facilitate a physiological response, and therefore a higher likelihood of wanting to seek drug and therefore use again. Stress and trauma, I looked at stress specifically, and how stress is a precipitator towards not only relapse, but also the development. And we're going to be looking at trauma as well. So these are all parts of the whole, and it's going to be specific to each and every individual, every person you come across. There will be patterns, but these are just things we need to take into consideration of some of the risk factors, contributing factors to substance use disorder. It should be no surprise if people use substances to feel good. Something Psych 101, positive reinforcement. What do? They produce euphoria by activating the brain reward circuit. Here, when we talk about reward, we talk about positive reinforcement, we talk about high, we talk about dopamine. Initially, within the neurosciences, that all came down to what they really focused on was the nucleus accumbens. So when you have a positive reinforcing effect, you feel good. This is also applicable to normal day, feeling really good throughout the day, and normal rewards, such as time with family, having coffee in the morning, having a good meal, relaxing. Also, this becomes supra-physiological, above physiological levels with substances, and they flood this area called the nucleus accumbens with dopamine. So you can see this is looking at concentrations of dopamine indirectly in the nucleus accumbens, and you can kind of see this is the front of the brain, this is the back, and somewhat right around that midline there on both sides. And there's a high concentration of dopamine in this brain. So substances induce euphoria, and it's linked to dopamine increases in the nucleus accumbens. And I'll be showing you a few different photos of that. Well, there's a lot of imaging, but it gives us an idea. So one of the things that is always good to keep into consideration is that our natural unconditioned state, it has been argued. And then one of the reasons I present this is because it flips how people suffering from substance use disorder look at substance use disorder. How being called an addict or accepting yourself as an addict or admitting that that's what's happening with your life, how do you flip that and give it some sort of empowerment and a new perspective that is just as true as if you lost control and now you're a victim to a neurobiological process. So in this process, your natural state, you could argue that your natural state is bliss itself. All experience takes place within existence or being, so you're here, you're conscious, and because you're here and conscious, and that gives you the opportunity to experience, therefore, it's blissful. But we have a bunch of conditioning. So if we remove all the layers and conditioning, underneath all of that, the true source of who we are could be argued to be blissful. So your true nature could be argued to be an unconditional state, which is blissful. And this bliss is either more or less evident at times as we go through our lives. And you could say, drugs do not produce bliss. They temporarily reveal your natural blissful state. So now you're taking an actualization away from the power of a substance and giving it to the individual. I've seen some shifts occur that have been very effective when we present it this way. And there's a key to balance. So balance is key to happiness. And the distinction between bliss and euphoria needs to be made. They're not the same. Bliss is contentment. It's the middle road. So bliss is perfect happiness and joy. These are just definitions. Contentment is a state of happiness and satisfaction. So happiness. Chasing euphoria is not advisable. We've all tried this in one form or another. Guilty is guilty, right? But euphoria could be defined as an extreme, unrealistic, unsustainable, for example, supraphysiological drugs. When I say supra, it means the body was not designed to be activated to that degree. And we'll go through the receptors and withdrawal intolerance. So you do have a feeling of physical and emotional well-being and being high, but it's extreme, it's unrealistic, it's not sustainable, and your body wasn't meant to be activated to that high degree. Therefore, there's going to be some compensatory responses as a result of chasing euphoria. And this is where substances and drugs come in. Now, I just want to cover some circuitry, the neurocircuitry of reward. This is the simplest circuitry, and this is looking at the dopamine pathways in the brain. So you can see here that you have blue and dopamine. You have glutamate, which is the excitatory neurotransmitter. So that makes things fire more quickly, more active. GABA, you can think about it as a red light. That slows things down. That's inhibitory. So that's going to be less excitatory. Within the VTA, that's the ventral tegmental area. In blue, that is where the dopamine originates, as well as the substantia nigra, which isn't shown here. That projects to different parts of the brain. One of the more studied circuits with direct effects on operant behavior as it relates to drug use is projections of dopamine to the prefrontal cortex and the nucleus accumbens. So that dopamine goes from that ventral tegmental area, so it's dopamine-containing neurons with projections, to the prefrontal cortex and the nucleus accumbens. And when we get activation and release of dopamine in these brain regions, this is where we get reward. So when we activate the circuit, that reward circuit, it induces neuroplasticity. Kind of like looking at your brain as a Play-Doh thing, right? That it's malleable, it can change as a result of, and you know, a lot of people will say neurons that fire together wire together. It's not quite that simple, but it's a good idea that what is used increases strength. So we could say that if you continually activate the reward circuit through supra-physiological activation of substances, that it's going to ingrain a pathway of activation through neuroplasticity that now only the drugs or the substances themselves can result in reward. So neuroplasticity is the brain's ability to change function in response to changes in their environment, but really it's about, at a physiological level, you're looking at activation of individual neurons. Look at it as electrical. We're all electromagnetic. Electrical being masculine, magnetic being feminine. They come together, electromagnetic beings. Neurosciences are looking at things as an electrical aspect, a circuit, which is a good start, and you can even apply physics and things like that. But really what you're seeing is changes in brain function of that circuitry of motivated behavior here as a result of drug use, and it changes function. And then you're going to have changes in the ability to control your behavior. And that is really where your volitional control over your behavior starts to be lost. So it could be, you know, this comes down to every action is equal and opposite and contrary reaction. In other words, if it goes up, it must go down. If it goes right, it must go left, etc. In an idealized world and universe, it wouldn't have to be opposite. It would be proportionally balanced. But under these circumstances that we're looking at, it is equal and opposite, and therefore you have to pay the piper. In other words, if you're going to get high, you're going to get low. And if you're going to get low, you could also assume that there's a high coming. But you're not going to escape the pendulum swing, in other words. So with repeated drug use, you have initially a feel good. Go from feeling good, you have positive reinforcement, you're feeling really good, you're high, whatever, if you're using a substance or something else. Repeated use over time results in a decreased positive feeling, feel good, and more of an enhancement of the negative. And so over time, there's a compensatory response of the system called homeostatic balance. So it will bring you back to neutral. It will always try to adjust itself. And when it tries to adjust itself when you're using substances, then there's going to be a pendulum swing, and the brain will adapt naturally to continued repetitive activation of the circuit. And that results in increased recruitment of the negative, feel poorly circuitry of the brain. So there's a switch from positive to negative reinforcement. You go from using a substance to feel good to using it to avoid feeling bad. So for negative reinforcement with repeated use, a lot of it, we can look at physiological withdrawal, and we'll cover the different stages of withdrawal, which is extremely important when it comes to how you interact with your clients, your treatment programs, and your objectives. Tolerance, you know what that is. You have to use more of it to get the same effect. It's a compensatory response as a result of continued exposure to a substance. Withdrawal is the opposite effects of the drug happening on the physiology after stopping use of it. So a compensatory mechanism, which I've already covered. Okay. So if we can just take a look at a synapse briefly, we can look at this first top synapse as the sender. And the bottom one here, that receptor, that's the receiver. And basically what happens is dopamine is released from the presynapse, the sender, and it goes to the receiver on the postsynapse on a receptor. It binds on that receptor and results in electrical conductance through that circuit that we had discussed, that reward circuit. And then that goes into the postsynaptic neuron, causing excitability of the reward circuit and the feeling of feeling good. So you have dopamine release, you have dopamine binding to the receptor, and you have reward. Okay, so with the case of cocaine, meth, stimulants, specifically, for example, the reuptake inhibitors, they're blocked. Sometimes they're reversed. So they're blocked in cocaine, and they can actually be reversed with methamphetamine. And what happens is you have a flood of dopamine in the synapse. With repeated flooding of dopamine in the synapse, what happens next is chronic binding onto the postsynaptic receptor. Okay, chronic binding on those receptors, initially it increases reward, but over time of activating those receptors, you have less receptors on this postsynaptic membrane, and you have less dopamine in the synapse and decreased reward. So the receptors internalize, and now you're not dealing with a system that can be activated by natural rewards. And over time, the same amount of drug no longer produces the same effect of reward. For example, they could say that, you know, if you do try heroin, you really only want to do it once because you're never ever going to be able to get back to the point of the first use. But you'll continue to search for that through the superphysiological responses. And we'll talk about how not everyone who uses or tries a substance becomes addicted to it or suffering from substance use disorder. Withdrawal phases. Basically, when you stop using a substance, you have dysphoria, opposites effects of the drug. We talked about that. These can be characterized from irritability, anxiety, anhedonia, and depression from hours to days after stopping use. And there's three main stages. And I looked at this, and we actually modeled the protracted abstinence with period through behavioral preclinical behavioral models looked at neuromechanisms of addiction and relapse. But you have acute withdrawal, typically between 48 and 72 hours. And this is where you see that physical withdrawal. You see sleep disruptions, anxiety, irritability, and crashing. And again, as clinicians and people working with clients, I want you to take these stages into consideration, and I'll explain why. Early abstinence, you have 3 to 6 weeks. And that's after stopping use. You still have craving, anxiety, uncertainty. You can have severe depression and irritability. So you can kind of see that the main distinction between early abstinence and acute withdrawal is the physical withdrawal, the term withdrawal. And protracted abstinence typically is greater than 3 months. You still have anhedonia, depression, and dysphoria, feeling poorly. That pendulum opposite swing of euphoria. And you still have a high susceptibility for relapse, but you've been abstinent for longer periods of time. Again, Philip Seymour Hoffman, years. He went years without using. He went back to try heroin. He used the same dose that he had when he was using in which he actually had tolerance. And so as a result, he overdosed because he no longer had tolerance. So if you go back and use the same amount of drug and you've been in protracted abstinence, could be years, that you used to use when you had tolerance, that's a huge risk for an overdose. So a relapse is actually, if you're in protracted abstinence, you go back and use the same amount of drug, then there's a possibility of higher harm. You know, there's a high risk there, in other words. So the longer you've been abstinent doesn't necessarily mean that it's going to be the best outcome if they do go back and use the same amount of drug or substance. So protracted withdrawal, what is it by drug, for example? So your acute withdrawal time for alcohol is 5 to 7 days. Benzodiazepine is 1 to 4 weeks, 3 to 5 weeks. So that's physical withdrawal we're talking about. So we're talking about physical withdrawal. So these are kind of roundabout estimates, ballpark, but you're going to be surprised as it is with substances. So you have 5 to 7 days with alcohol, benzodiazepines, 1 to 4 weeks or a month, or 3 to 5 weeks with tapering. Cannabis is 5 days. Nicotine is 2 to 4 weeks, which is much longer than I had suspected. Opioids is 4 to 10 days. And stimulants, amphetamine, it's 1 to 2 weeks. 1 to 2 weeks, you're in a physical withdrawal, acute withdrawal period stage. So I ask so this needs to also be integrated and assessed when you're working with people and individuals that are suffering substance use disorder. Identify their drug of choice, identify when was the last time they used, what is the susceptibility, and what preventative measures can be implemented and acknowledged. So for protracted withdrawal, you have different terms for it. So if you go across the literature, you have chronic withdrawal, extended withdrawal, late withdrawal, long-term. Okay, so basically post-use, sobriety base. Anyways, they haven't used for a long time, but there's some synonyms there. And then what are some symptoms of protracted withdrawal? Pretty much the same dysphoria in general. You have anxiety, sleep disturbances, problems with short-term memory, fatigue, problem concentrating and making decisions. You still have drug cravings. So even in protracted abstinence, you have cravings, impaired executive control, which facilitates the vicious cycle of addiction, not feeling pleasure, except for only when the substance is there. So they'll go through a period of not being able to feel pleasure through normal life, which is one of the key determinants of relapses as well. And you have a difficulty focusing and being productive in your life, irritability, physical complaints, decreased intimacy. So the list goes on, but gives you an idea. And so in other words, but you need to know that protracted withdrawal symptoms are not the same for all substances. So basically, I jumped ahead. I went and said, okay, so let's go to the protracted withdrawal period, long-term stabilization, long-term maintenance, and relapse prevention, if we get to that point. The withdrawal symptoms from the protracted period are not the same for all substances. Not all clients, importantly, will experience protracted withdrawal. And to treat protracted withdrawal education, you have realistic recovery attitude. You celebrate each accomplishment, assess for co-occurring disorders, which is extremely important. Ask about sleep, activity, skills development, meds as needed, support groups, executive controlled development, and monitoring. I know this is just repeating in this for a lot of you on things you do on a regular basis. So a lot of the things that you are already doing are essential to long-term maintenance during the protracted withdrawal, also for long-term stability and relapse prevention. So when we look at some of the implications for providers, it's good to be able to take consideration of the providers as you're going out there, because we're seeing a kind of an upswing in decriminalization, and we're also seeing an upswing in how what level of particular substances are reaching the population. And exactly, a lot of people are in a lot of pain, and we're going to cover that in the more holistic integrative approach as to why people are using more than we had before. But patients with a substance use disorder are more likely to exhibit physical conflict towards providers. alcohol, cocaine, methamphetamine is more consistently associated with physical conflict than heroin or marijuana. So there is a little bit of specificity with what substance is being used. Importantly, post-traumatic stress disorder is number one for risk of a physical conflict, whether that be with a provider or society in general, and then conflict with the police, etc. But the ones with the highest rates are those with PTSD co-occurring disorders, which involves either a mood disorder and or substance use disorder. And it's pretty safe to say that a lot of times these do overlap significantly. And this can maybe result as direct high or effect of the substance on the individual needing and seeking the substance, withdrawal from the substance, these all, and then on top of that, impaired executive function and impulsivity as a result of repeated drug use. So in other words, the client stage of use, abstinence, withdrawal, and conflict resolution needs to be taken into consideration for an effective treatment plan for both client and provider. Okay. So now we're going to go back to looking at the brain. How is everyone doing? Any smiles over here? A bunch of beautiful faces. Still with me? All right. See a few thumbs up. Thank you, Jay. Cynthia, awesome. So, what are we seeing here? We're seeing basically normal brains. On the left, control means normal, no drug use. On the right, substance use disorder. What do you see? Less red. Remember, red means high dopamine in direct measurement. What does that mean? Well, guess what? Now, those who are suffering from substance use disorder have dopamine hypoactivity, meaning they have less dopamine in the brain. That's all it means. Less reward, less dopamine as a result of continued drug use. It doesn't matter what substance you prefer to use if it's repeated. And we all know that sometimes it's a cross contamination or toxicity or cross abuse use, but what is one of the things that's driving behavior in these clients is hypofrontality, where, as you can see, you have a neutral theme above, and then you have a cocaine-related theme on the bottom. On the left, you have a control. On the right, you have one suffering from cocaine-specific substance use disorder, cocaine use disorder. And when they give an interview that's related to cocaine-related stimuli, the prefrontal cortex or the frontal cortex, a different part of the orbital frontal around the eyes, but specifically the cortex will activate only in response to a cocaine-related stimuli, but not normal, neutral. So what is this really saying? This says that the prefrontal cortex is streamlining activity towards drug or substance-related stimuli specifically at the expense of natural or neutral rewards. So that pendulum swing, the opposite reaction of the substance, withdrawal tolerance, internalization of the receptors, all these things within the reward circuit. Now, only that circuit becomes activated as a result of substance-related stimuli. So that's great, and everyone's on this dopamine, but not all drugs of abuse result in detectable increases of dopamine in man, Dr. David Nutt. And so that means that it's not all dopamine. We have a plethora of neurotransmitters that interact together. Again, we need to take a holistic, integrative approach to how this works. So beyond dopamine, what do we have beyond dopamine? They have said that some dopamine mechanisms for addiction have not been as effective as they had predicted. Dopamine can be protective against addiction, meaning that those who have a certain level of dopamine actually are less likely to develop addiction because they have that innate reward circuit. Those who have a deficit of dopamine are more likely to show drug-related stimuli. Other roles for dopamine, besides reward, include habit, impulsivity, compulsivity, and that involves the prefrontal cortex, those projections to that area, the nucleus accumbens, we talked about that. So these brain regions aren't just reward, there's functions. And I can tell you, when you go into the literature, you can pretty much find a function for any part of the brain for something you look at if you dive deep enough into the brain itself and look at interconnectivity and wholeness and integration. So we could say dopamine, sure, that's pleasure, wanting reward. We have GABA and glutamate. Again, GABA is the inhibitory, glutamate's the excitatory. And you also have endorphins. And this is pain reduction. And we're going to talk about how pain plays an an important role in the likelihood and propensity to develop substance use disorder. We'll talk about serotonin as well. So we're looking at other neurotransmitters, serotonin being involved in meaning, impulse regulation, control, and sense of self. And alcohol and amphetamines have also been shown to release endorphins in both the nucleus accumbens and frontal cortex. Again, so endorphins being released in that reward circuit in addition to dopamine. And that Dr. David Nutt will argue, who's kind of going, against the grain a little bit, or the canonical academic that was a few decades ago, beyond dopamine, in other words, that endorphin blockers are effective in treating addiction, but compliance can also be an issue as well, looking at that. So I know this is a complicated slide, but this is a really good slide. If you ever want to know what the natural occurring opioid aspects of the body are, here you go. You can go here and reference what receptors, what are some, and 1 through 4 on the top are basically the natural endorphins, so types of naturally occurring opioids. So we have a system in our body that is naturally there to have function. And then substances kind of step in and utilize that and activate it more than these normally would. You have different receptors along there. So when we think about opioid peptides, endorphins, we're really talking about neuropeptides, which are proteins that act as neurotransmitters within the brain in various parts of the brain along the brain stem. So now I want to make a shift. That is generally the disease model. And let's go beyond the disease model and hand ourselves an olive branch and ask the question, was it the chicken before the egg or the egg before the chicken type thing? But educating how the brain works with drugs, how drugs change the brain, and how the changes of the brain control behavior are only a part of the story. Took me a long time to figure this out. I know, sometimes in hindsight, wow, all right, took me way too long. But these effects demonstrate the difficult symptoms, but not the true cause, according to some experts. Most people who try drugs do not become addicted or suffer from substance use disorder. To truly get to the cause, you need to determine what was the underlying need to use the drug to begin with. So why did they use it, and what makes them more susceptible to becoming, to suffer from substance use disorder? What's going on? Trauma. So I'd like to introduce Dr. Gabor Mate. If you haven't heard of him, he's a very compassionate, brilliant man. And he has argued that addiction is not a disease. It is a doomed attempt to solve a problem. It causes a disease. And some of the information from Dr. Nutt and Dr. Gabor Mate came from the Imagination and Addiction edition. Shout out to the Master Series. They do an excellent job. So keep an eye on some of those educational opportunities as well. So he'll argue that trauma is the root of all addiction. And you have 2 types of trauma: an emotional response to a deeply distressing, disturbing experience. That's the traditional trauma response that we're used to looking at. Okay. And then you have a second response when your needs are not met. This is misattunement, according to some people. So, all right. Misattunement is when you have when your emotional or other needs are not noticed, reflected, or met. And what's really kind of interesting is we are always focusing on the emotional response to a deeply distressing, disturbing experience. But for people who are sensitive, we've heard empathic, who have a narcissist empath dynamic as childhood, you're really dealing with within these sensitive children and neurodevelopmental stages that a lack of attunement can be very, very wounding and a significant source of trauma. Okay. So now we're going to look at emotional pain. And I'm just going to take a step back here. Figure out something. Okay, good. So emotional pain. This is a part of psychology, it's part of physiology, it's part of the brain, it's part of all that is. So we'll think about these parts of a whole where they come together. And addiction is craving pleasure for short-term relief, leading to long-term harm and an inability to give it up. Well, that makes sense. You're trying to avoid emotional pain. So he'll argue that it's not why the addiction, but what is driving pain. There's many forms of pain, and it's a really good teacher, but it's also a huge source of avoidant behavior. And one of the things about substance use disorder is you really have to tackle the avoidant behavior right up front. And that's kind of literally where the literal courage comes in, where the support comes in, and knowing that you're going to feel very poorly for a certain period of time. But knowing that by putting up with feeling poorly because of withdrawal or tolerance, that's a sign that you're going to feel better. And what level of pain is that, you know? So compassionate inquiry involves relieving shame, getting rid of shame. And I'm going to talk about how shame works energetically as a result of patient outcomes. And so again, the chicken or the egg, he'll argue that it's not their brain circuits, but their lives. Okay. They're not separate, but let's take a look at each thing. So addiction, shame, and self-love. Shame produces disconnection, facilitating and resulting in repetitive unwanted behavior. It produces disconnection. This, in other words, is separation. And so you're really looking for wholeness, and you're looking for connection as the source of treatment for substance use disorder. Any form of shame will actually facilitate that repetitive behavior. If we go back and think about our life where we had guilt or shame, did guilt or shame prevent that behavior from being repeated? Does anyone have an input on that? If you felt guilty or shameful, was that behavior able to be prevented?
It makes it a lot harder.
Makes it a lot harder. Yeah. So one of the things to keep in mind is that it turns in on itself. You have a feeling of unworthiness. And that unworthiness is really kind of the polar opposite of what you should be targeting for the treatment of substance use disorder. And so this is where education, empowerment of the client, and unconditional love and holding a non-judgmental space through compassionate inquiry to remove the shame is critical at an energetic and neurological and physiological level. So,
Dr. Blackstone, I have a question for you.
Yeah.
So I was raised in a fairly conservative evangelical home, and so shame created a sense of accountability. And I maintain a lot of the values that I grew up with, but I reject the notions of my parents' faith persuasions, but what is your thoughts as a clinician that
Mhm.
shame and accountability and where those two possibly meet in this context?
Well, I could say that you have to take accountability and that we have to take responsibility of our lives, of what happens in our lives. And accountability is essential. But you don't have to involve shame and accountability. You can be accountable without shame. You can take responsibility without shaming yourself. You're not going to make it without taking responsibility for your life. For someone who is deep in the throes of a cycles of substance use disorder, until they take responsibility, it's not going to happen. But shame, that's not going to help either. So put shame on the shelf, put guilt on the shelf, accept it for what it is, work through that in any process that works through with your client or yourself, because we're all healing ourselves and then we help heal other people. It's part of the journey. But then what? Take responsibility. Take accountability. And that accountability and responsibility doesn't have to be what other people are putting onto you. It can if it's resident and you align with it and you agree with it. And that's where the intuition and intellect come together, where you feel into it. What is right for you, Matthew? Right? In a particular situation. What a piece of information from this do I accept? And what bit and piece of it do I not? And so in order to figure that out, you put shame and guilt on the shelf for a second, and you look at it objectively. You feel into it. Beyond the intellect, you bridge the intellect with the heart and the intuition. Heart-brain coherence, which is really critical, and I'll bring that in. And then that allows you to facilitate an objective observation. An objective observation, or what I call observational consciousness. And this is mindfulness, and we'll get into that. It's where mindfulness comes in, where you can observe yourself without a bias and a compassionate way.
This is a huge paradigm shift that you are speaking to, and I have much appreciation as dealing with two teenagers and a preteen, as well as being a clinician. So you're challenging some assumptions that I needed challenged, and I appreciate your context.
Well, I appreciate you, Matthew, and your interaction. And it's really just at that point, sometimes it's good to ruffle feathers for growth, not necessarily that it's correct. And we have some other questions. I think Jared was first. Go ahead, Jared.
More of a comment, just something I use to try and address this in sessions with my clients is separating fault and responsibility. A lot of time with the conservative cultures, especially, shame comes with trying to find or place fault, like who's responsible for this so that somebody will take responsibility.
Yeah.
But the things that cause people pain don't necessarily come from something they did. But it doesn't mean they don't have a responsibility to address it.
Yes.
So it kind of takes away the just world fallacy. Like it's not just that you have this responsibility. It doesn't change the fact that you have this responsibility. It's not just that somebody else got away with the same thing. They don't have the responsibility, but it doesn't change it. So the shame is kind of a moot to how you need to move forward. So we just try and decouple them in sessions.
Yeah, that's fantastic distinction. Thank you, Jared, for the input. Avril, did you have a question or comment?
Yeah, it was a comment. It was just, I was just going to agree with being accountable for your actions while in active addiction and being responsible for your actions also, that it's so important to be open and honest with yourself to be able to move on with that shame.
Yeah, absolutely. Thank you for that. I can agree with that wholeheartedly. Okay. So we could also make the argument that the opposite of shame. So this is at Coos Health and Wellness, and I asked a question. Someone, what is the opposite of of shame. So confidence, well, kinda. Self-love, maybe. Peace. And so you're actually taking an approach towards substance use disorder with connection and peace and self-love, not shame. So we can look at connection and peace, wholeness, self-love, whatever that means to you, compassion, self-compassion, as a treatment, as an approach towards substance use disorder. So this is an important aspect here to avoid from that energy turning in on itself. Okay. So just do a comparison. You have shame. It causes disconnection. It causes separation, increased drug use, increased relapse. Self-love, connection, peace, decreased drug use, and decreased relapse. And I would really like to see some of the clinicians to observe themselves in this way. Observe yourself using observational consciousness, interacting with how your behavior is affected under different emotional states and approaches, and continually improve through observations of yourself and your clients. And this is part of personal evolution, which is an important aspect of existence. So this comes into Brené Brown's shame resilience theory, where the goal is to feel the opposite emotions from shame. And she mentions connection, empathy, freedom, power, self-love. I'm going to go ahead and say that freedom, you are not going to be blissful or happy without freedom. So freedom is pretty much the opposite of substance use disorder, right? So keep in mind that we're looking at polarities, sure, but really what are we doing when we combat one polarity with another one? You're coming more to a neutral balance point where you have happiness through balance, So then we're going to take more of a specific approach. I'm going to give people a bio break at 1. I think now is a good time. Do we do bio breaks? Or are we good? Are we going to go power through it, Angela?
I
Could
think
people
maybe,
use a bio break?
yeah, let's do a 5-minute
right.
bio break.
All right, I'm going to see what slide number I'm on and go to the bio break. I'll see everyone in just a moment. 5 minutes.
So will we come back at 10:07
All right,
Pacific time?
sounds good.
Okay, we have about 1 more minute before we start back up.
All right, Angela, can you hear me and see my slide?
Yes.
Fantastic. All right, we're about halfway through, so I might pick up the speed a little bit, but bio breaks are good. Okay, especially if you've had caffeine or water or any sort of liquid. That's part of being human, I guess, right?
I did have a question come in. You referred to a phrase, observational something, about watching our actions, reactions. What was that word?
It's a term I came up with that came through some other teachings I came across as well. So when you observe yourself in an unbiased way without, it's a mindfulness approach where you use observational consciousness, where you're simply observing yourself. And that's part of mindfulness, where you allow the thoughts to come in, but you don't engage with your thoughts. You let them come and go. So that's where the mindfulness approach comes, like when they talk about waves coming in or clouds floating in or out, our brain's always going to have thoughts, is what it does. But you can watch them. You can take a back seat and just observe your thoughts, simply observe your interaction with the world in a curious state. You know how you people watch when you go out next to the road, right? Or you're in a busy place. I don't want to go shopping. I'll people watch instead. Kind of like that, except you're watching yourself, interacting with your reality. And you can see things in a much more clear way and an unbiased way, an unconditioned way. And that helps you uncondition the mind. And that's going to become very important later on. So this is where mindfulness and neuroscience come together. Okay, I'm going to go ahead and get started with the second half as we enter into epigenetics. You know, epigenetics is a study of heritable changes in gene expression. They can be activated or inactivated. They don't necessarily involve the underlying DNA sequence, and they can change your phenotype, or in other words, how you look, without a change in your actual DNA sequence or your genotype. You can turn on cells and activate genes. And as we move forward and as science evolves, they're going to find that the non-coding RNA, the non-coding junk DNA, all of these things are actually not junk, and that there's coding underneath all of that, and it just hasn't been activated or put into sequence towards activation correctly just yet. So what we're going to be really looking at is how epigenetics interacts, and a very important way of looking at things. Like ego, the epigenetic overlay. So conditioning, ego conditioning happens at a genetic level. Okay. My slides stuck? I hope not. Let's see here. There we go. Okay. So the epigenetic overlay, or the epigenetics, is a key to forming your personality, your sense of self, your conditioning, and your belief systems about the nature of your reality. So in other words, it takes all the way back to the chromosome, where your histones and your genes and all of these things, they can either get more loose and more accessible, and they can get tighter and least accessible. You can have, with each cell division, a decrease in the chromosome length. So you have all of these different interactions at a genetic level. It's not a molecular biology course, and I would let someone else teach that anyways, but this gives you an idea of what happens at a genetic level. Gloss over. So epigenetics plays a key role in trauma and how that interacts with our DNA and also with our mind. So in other words, circuits don't develop, if you have trauma, the circuits in the brain don't develop properly and produce an addicted prone personality. We also know that trauma can be translated to multiple generations. So can substance use disorder propensities. And emptiness, a sense of deficiency, shame again, there is that term again, and inability to be with the pain are a facilitator of substance use disorder as it relates to trauma. So you can make the argument that substance use disorder is not genetic, but that the genes that they're actually looking at that are coding for substance use disorder or addiction in the literature is actually coding for sensitivity to pain. So it's an interesting theory that Garbamade introduced, that these genetic sequences that they're correlating with substance use disorder are actually coding for sensitivity to pain instead of addiction itself, and that the underlying cause is sensitivity to pain. We talked about misattunement, not getting your emotional and other needs met for sensitive people is a form of sensitive pain, and that people with certain gene codes could have these sequences found in their DNA. So we could also take a social perspective. We can take a genetic perspective. We can take a social perspective, substance use disorder. This does not deny that each individual vulnerability, but also posits that social determinants are a powerful factor. We know that this is true, right? We can observe it. So one cause that was very interesting is the globalizing free market society capitalist system. That we are now under a time of socioeconomic stress, individualism, and competition, which produces separation, pain, despair, and a need to fill an inner void. So there's a contributing factor socially to all of this. And I highlighted separation and pain. And again, The opposite of substance use disorder or addiction is connection and inner peace or wholeness. Okay. So stress trauma in the brain. I'm going to cover the sympathetic nervous system and parasympathetic nervous system very briefly, but in other words, this is part of your stress response: fight or flight, rest and digest. You have different propensities of glucose expenditure versus storage, blood flow, heart rate, ventilation. You get amped up or you get amped down, basically, right? But I like this because it's showing you that the end game of the parasympathetic system is acetylcholine, whereas the end game of sympathetic nervous system is norepinephrine. And so based on the transmitter that's released, it can be relaxing or excited or not relaxing or preparatory, so fight or flight or rest and digest. And also that there's direct communication to the adrenal gland, the adrenal medulla, where epinephrine and norepinephrine comes from, but you also have the adrenal gland, where 80% of that comes from as well, and cortisol, which we'll talk about on the adrenal gland as well. So within attention hyperdeficit disorder, you have a dysregulation in the brain involving increased norepinephrine. So you can think about the locus coeruleus of norepinephrine in red. And then we talked about dopamine, the substantia nigra and the VTA briefly, the blue, where there's actually a decrease in dopamine signaling in the areas of the brain. They go to the prefrontal cortex. Striatum, again, if you recall, the nucleus accumbens is involved in that brain region. So people with decreased dopamine and increased norepinephrine are amped up, decreased reward. So a decreased dopamine, you're wired to seek more, increased addiction risk probability, and they have actually labeled this as a reward deficiency syndrome. So you have altered neurocircuitry that involves areas of the brain in memory and emotion, okay? When you see chronic stress, you have the adrenal glands activated, you have release of epinephrine and cortisol from different parts of the adrenal gland, goes to the bloodstream, that communicates with parts of the brain, and through neurotransmitters, you have the hormone, corticosterone, and you have the neurotransmitters, norepinephrine, CRF, corticotropin releasing factor, and these activate receptors in the memory and emotion aspect of the brain. And so you're getting this direct communication with the brain and the stress, and then this facilitates propensity to develop substance use disorder. Interestingly enough, when you use substances consistently, the neurocircuitry of negative reinforcement, it becomes activated, where the anti-reward systems recruited as part of that homeostatic balance. One area that can be looked at is the amygdala. It's involved in emotion and memory, amongst other things. And with repeated drug use, you have an increased strength of the conditioned responses of both emotional and stress reactivity, which increases cravings further. So again, this is just giving you how the anti-reward system, that pendulum swing, that equal and opposite reaction happens in the brain. And here you're looking at an activation of the amygdala in relation to cocaine-related cue in an individual on the right here. And that's being activated. That's the amygdala being activated by cues. So they're emotional. Memory, emotion and memory are very closely related. We think about music. Imagine that coupled with a super physiological substance, and you can imagine the strength that these have on operant behavior. So if I was to say we could summarize depression and PTSD in a simple slide, there was a seminal study by Robert Sapolsky. I don't know if you've heard of him. He was looking at subordinates and dominant monkeys in the Sahara. But what he really found, and that was a great model for depression, where he was able to look at cortisol levels and something called the hypothalamic pituitary adrenal axis, basically your stress signaling. And basically what he found in major depression, you have increased cortisol concentrations and you have increased CRF levels. So there's something called negative feedback, where it shuts off the stress circuit at a particular part of the circuit, your anterior pituitary. Don't need to go into details, but basically it shuts off the stress response. When you have depression, your shut-off valve doesn't work properly. So you're more stressed out, you have increased stress hormone, and you have stressful neurotransmitters running through the brain and depression. So if we look at PTSD, what's happening on that level, they actually showed that there's decreased cortisol versus depression with an increased cortisol compared to a normal person. So that's basically what this is showing. And so really, what does that mean? It basically means that you have increased circulating stress-related neuropeptides, but you have an increased feedback as a compensatory response. So basically, the shut-off valve is dysregulated in both depression and PTSD, but it goes in different varying degrees. And this is a facilitating factor, or has been correlated at least, not necessarily causative, to substance use disorder. So substance-induced neuroplasticity is a perfect storm to drive addiction. How? It decreases reward. So you have decreased dopamine and reward in the nucleus accumbens. It decreases frontal cortex function, or inhibitory executive control, and it increases amygdala function, or emotional reactivity and memory. And these are all activated by cues, stress, and drugs that drive the compulsive and impulsive drug use. So treatment, abstinence. So that was why I was harping on the different stages of abstinence. Critical. Abstinence is critical. And you can see here in a healthy control and a patient with 1 month of abstinence from methamphetamine versus 14 months that the brain can actually bounce back through neuroplasticity. So drug-induced neuroplasticity occurs, and so does abstinence-induced neuroplasticity to come back to a healthy, normal state. How do we treat? A lot of this you could probably teach me more, but you have a pharmacological intervention by blocking the craving, the euphoria or dysphoria aspects of the cycle, cognitive behavioral therapy, strengthening executive function, and your intervention programs of reinforcement of desired behavior and abstinence. So you target the addiction cycle. You can target feeling good, feeling bad, and the craving itself. So looking at craving, euphoria, dysphoria. Prevent dysphoria, prevent euphoria, and prevent craving, basically. Break the cycle. And here are just some examples of meds that have been on the market that show varying degrees of efficacy. And as a lot of you know, cognitive behavioral therapy, what does it do with the brain? It suppresses drug seeking by strengthening executive function, especially at times of high relapse risk. Contingency management, you reinforce your desired behavior and withhold reinforcement or punishment of undesired behavior. So that's looking at positive and negative reinforcement. And community reinforcement approach. You rearrange one's life so that the abstinence is more rewarding than the substance, shifting positive reinforcement from the drug to sobriety. And this is shown at a neuroscientific level. This is community reinforcement models have been extremely effective, and I'm guessing that some of you could weigh in on how that's worked with your clients. But with all of this, we're going to be taking a different approach. The first kind of progressive program I had heard of was years ago. It involved Families Against Narcotics, Hope Not Handcuffs, looking at a cooperative between law enforcement and community organizations to find viable treatments for individuals suffering from substance disorder. And treatment, you're really looking at support, compassion, respect, and coordination amongst the front lines. Your healthcare workers, your mental health providers, and the police departments. And as a lot of you know, in Oregon, they passed the Drug Addiction Treatment and Recovery Act, Measure 110, which is shifting in how we're able to adapt. And a lot of you are on the front lines over there, and how to look at this new health-based approach of addiction. So they're looking at the health-based approach as more effective to treat overdose and more cost-effective than criminal punishment. In other words, making people criminals because they suffer from addiction as a disease is more expensive, ruins their lives, and makes access to treatment and recovery more difficult. And you could even go further along to say the whole emotional aspect as well, removing the shame and coming from a health-based approach versus something other. Okay, so we have 3 brains. I know it all's coming together in different ways, but we're gonna have different phases. So we've covered a lot about the brain, and this is where that mindfulness comes in. So you have 3 brains. You have the head, we know that. We have the gut, the heart. These are different neural plexuses and different parts of your body that process information and are interconnected. So heart-brain coherence is something I had looked at, and this involves correlation, connectedness, consistence, and efficient energy utilization, wholeness, and global order. In other words, you have connection and wholeness, where the whole is greater than the sum of its individual parts, which is a gestalt, right? So in heart-brain coherence, the heart communicates to the brain more than the brain does the heart. And this is evidenced by the physiology and how they're connected. The heart sends more projections to the brain than the brain does the heart, suggesting that we should be communicated to the brain from the heart. And this results in heart-brain coherence, which facilitates oscillations of the cortex in a way that is coherent, well-coordinated, positive emotional health, optimal interactions between your physiology, your cognition, your emotional systems, wholeness. And there is one particular place is looking at the possibility of heart-brain coherence and its effect on its ability to facilitate substance use disorder recovery. It's been found to strengthen emotional self-regulation or executive function. It synchronizes the physiology, facilitates resilience, greater connection, and facilitates relapse prevention or abstinence. So by communicating between the heart and the mind, engaging the intellect with intuition and neurophysiology, the heart, mind, and heart-brain coherence, you can facilitate efficient recovery. And then we're going to talk about the polyvagal theory. We know that the brain connects with the gut. Poly meaning vagus nerve, many vagal nerves. This is one of the key nerves that we need to fully understand to heal trauma and restore health back to our nervous system, because we hold trauma in our vagal nerve. So this is a neurophysiological foundation of emotion, attachment, communication, and self-regulation. Specifically, when we think about the sympathetic nervous system, we're thinking about, you're ready to rock and roll, basically, right? Ready to, you're going to either survive or you're not. We think about parasympathetic, we typically think about rest and digest, but there's a ventral aspect, which is about connection, response, and compassionate state, which is very important, that really relaxation, connection. There's also a dorsal vagal system or a primitive area. And this is where trauma is stored. And you have immobilization, frozen, numb, dissociated states. So when we talk about immobilization, frozen, dissociation as a result of trauma, when that person's interacting with their environment and you're starting to see this, it's literally an imprint on their dorsal vagal system, which is in their gut, which communicates to their brain, and then it affects their operant behavior. So trauma is one fundamental cause of both mental health and substance use disorders. And one of the things that I like to introduce that you're well aware of is eye movement desensitization and reprocessing, EMDR. It has been found to decrease craving, fear, depression, and increase emotional stability and self-esteem in those suffering from substance use disorder. So if you are EMDR certified or you're going to become EMDR certified, I would suggest really looking at the possibility of integrating EMDR as part of your substance use disorder treatment plan. There are protocols available for you out there called the desensitization of triggers and urge reprocessing, where you can combat addictions and dysfunctional behaviors with the underlying aspect being trauma itself. And so you say you have a known trauma, and then you have a known behavior. So use EMDR for the known trauma, and this desensitization of triggers and urge reprocessing, detour, for the behavior that you'd like to address, which would be operant seeking of substances many times, especially at times of high craving. You can implement it into your treatment plan, all coming to that hybrid of behavior and trauma back to the trauma known, behavior known. That direct connection between behavior and trauma. So let's take a look at mindfulness. It's all the rage nowadays, right? We use this term. And I would like to straight up tell you that this involves empowerment. And I'll define mind versus brain, mindfulness. If you are full of thoughts, that's not mindfulness. If you are full of consciousness without thought, then that would be what you'd want as a result. And that means that the mind is consciousness, not thought. The brain's more associated with thought, but you got to just keep in mind what definitions you're working with. But empowerment, you have a delicate balance of holding self-empowerment while releasing the illusion of power the drug creates. So we talk about releasing to a higher power. Actually, you empower yourself by releasing control. It's kind of counterintuitive, but it facilitates what happens in 12-step to some degree. And then that a lot of times that's hindered by shame if that continues too far in that program, depending on the setup. And then you have an increase in self-awareness. And this self-awareness is where the techniques come in. You have cognitive behavioral therapy and meditation and yoga. And the idea is to expand your consciousness to a transcendent state that's beyond the self, a little less, beyond the conditioning, the epigenetic overlay, the conditioning we've accumulated. Because you have to get past that conditioning in order to observationally observe, and then that allows you to make changes. A lot of this has to do with bringing things from the unconscious conscious, and then when things are conscious, you can make moldable changes in behavior. And just to make the argument, it took me a long time studying the brain to figure this out, but looking for consciousness in the brain is like looking inside a radio for the announcer. What does that mean? Again, let's go back to the unconditioned state being bliss. You exist, you're being, you're experiencing, you're conscious. Because you exist in your conscious, you can feel bliss, which is happiness. So your unconditioned state being bliss. It never leaves, it's either more or less evident. And the drugs do not produce bliss, they temporarily reveal your natural blissful state. Well, that's great, but let's go back. Bliss is not euphoria, it's contentment in the middle road. Bliss again, perfect happiness and joy, contentment, state of happiness and satisfaction, but chasing euphoria is not advisable, again, extreme and unrealistic. Feeling of physical and emotional well-being and feeling high, super physiological. Just to review that again, that point. Because the brain could be defined as a soft nervous system organ within the skull functioning as the coordination center of sensation, intellect, and nervous system activity. That's the brain. The mind could be defined as a combination of your brain and consciousness. Consciousness, physics, quantum physics is telling us that's energy. All energy, all is energy, all is mind, all is consciousness. It's not just limited to the proximity of the skull, basically. You're more of an antenna than you are an entity of consciousness physiology within an individualization. So energy can neither be created nor destroyed, and it can only be converted from one form to another. What does that mean in a sense? So then we take that and we look at the brain. Well, let's take a look at the default mode network. It's a particular part of the cortex that's activated when you sense yourself, your sense of self. When you sit here and you look and you say, oh, Jordan's in front of the computer again. Cool. All right, what's going on? Well, the sun's coming in and it's kind of covering my face. I wish they could see a little bit better, but the lighting's not perfect, but it's a cool room. Okay, I'm talking. Well, it's really the medial frontal parietal network. It's activated and it controls how we relate to ourselves. So I'm introducing this because we need to go beyond the self. So let's take a look. It's basically you have increased activity of this network and connectivity in depression that causes rumination. So you have an increased sense of self and rumination in depression. And this is showing you these photos there, and these citations are there. And you have abnormal function and connectivity of the DMN in addiction, craving, and relapse. So you have an augmented sense of self. You have increased activity and decreased connectivity. So activity and connectivity are not the same thing. Sometimes when you're more connected, you have decreased activity. So increased sense of self and decreased executive function in addiction is associated with craving and relapse. This area of the brain is engaged during withdrawal and preoccupation phases of the addiction cycle at the expense of executive control. So you have dysfunctional connectivity that is associated with craving and relapse in the area of the brain that regulates the sense of self. This does regulate dopamine and glutamate and GABA, as well as the acute and chronic effects of drug use. And it increases the increased sense of self that people have in this circuit is relieved by using drugs. So when we bring mindfulness into the picture, it actually reduces that area of the brain that codes for the sense of self. It decreases that activity of that area, but increases connectivity. So you're more connected and the sense of self circuit is not as active. So you're more present. So this means that you're present. Presence. Observational consciousness, presence. So increased connectivity. This is a neuroplasticity change in the brain to decrease the activity and the sense of self. So you increase the connectivity of the brain to decrease the activity of the sense of self circuit. And then therefore you have alleviation and what we call mindfulness and presence. That's just an indirect indicator, but it gives you neuroscientific data and evidence. So when we're looking at mindfulness, presence, or observational consciousness, this is a transcendent state, transcending beyond limitations and boundaries, beyond the little self, the conditioning, the epigenetic overlay. It enhances neuroplasticity in the reward circuit, and it results in activation of the cortex and the nucleus accumbens. So it activates the reward circuit. So mindfulness can activate the reward circuit and change the way the brain functions. Specifically, so we talked about how substance use disorder has a decrease of dopamine in the nucleus accumbens and prefrontal cortex function as a result of substance use disorder. So if you are increasing dopamine in the nucleus accumbens and you're increasing prefrontal cortex function, it's the antidote to the effects of substances on the reward circuit itself. So, mindfulness considerations. You have a long-term commitment, not a short-term fix. It may be difficult during the addiction process. You can imagine that mindfulness, when you're going in the different stages of substance use disorder, is very tricky. And the fear or actuality of triggering past trauma is real, because we need to have trauma-informed meditation and mindfulness practices, because a person with trauma can dissociate because of that dorsal vagal aspect, the polyvagal theory. A person with trauma can dissociate during mindfulness practices and meditation. And then trauma can actually come in as an unbearable physical sensation during this time. And so you want to incorporate movement into the mindfulness to minimize those aspects of dissociation and unbearable physical sensation that trauma creates. And so things such as yoga to incorporate movement, and this comes from Vander Kolk in his work. So to address that, we're looking at mindfulness and conflict resolution, which is extremely important. And I'm going to touch on psychedelics and addiction as it relates to the sense of self. So drugs and medicines, let's just define those. Drugs produce a biophysiological effect. Medicines treat disease. Addiction is rooted in trauma and unresolved emotion. Psychedelics are both a drug and a medicine that provide insight and learning. So what happens with psychedelics? With decriminalization, legalization, and everything's going on. It allows you to move beyond the conditioned personality to touch the true self, the big S, to treat dis-ease. It all comes down to set and setting. And that's why the foundations are maps are all these, and we're getting trained in set and setting. But and the focus has to be integration over the experience. So I'm asking, are you moving horizontally or vertically? Horizontally or vertically, not in the sense of direction, but like in a football game. The goal is to get a touchdown, right? In order to get a touchdown, you have to go vertical and gain yardage. So are you going where you want to go when you use a psychedelic? So this is where I ask, well, you have to discern whether it's going to be an altered state of consciousness or a transcendent state of consciousness. In other words, are you not gaining any yardage? You're just changing in where you are, but you're not gaining yardage. Or are you transcending and going beyond boundaries and limitations and going vertical towards that end goal of a touchdown, basically? This is critical when it comes to integrating psychedelics into consciousness evolution as it pertains to trauma treatment and substance use disorder. So the experience of altered consciousness versus the integration of transcendent consciousness is what needs to be prioritized. Because there's plenty of use of psychedelics that's altered, but it needs to be integrated and transcendent. So serotonin, when we talk about psychedelics, we're talking about serotonin a lot of the times, and that's involved in self-control and sense of self. So just to go back to that slide. So we look at mescaline, psilocybin, LSD, ayahuasca, ergot. You see a lot of serotonin, specifically the 5-HT2A receptor that is activated by these substances. And here's a look at the 5-HT2A receptor in the human brain. It is everywhere in the cortex. So it activates the cortex globally. And again, psychedelics can uncouple the default mode network connectivity that encodes the sense of self. So it's uncoupling some connectivity. It has been shown to be somewhat effective in treating rumination and resistant depression. And they produce an increase in connectivity globally throughout the brain. Okay, so as a result, it can increase the connectivity, not necessarily the activity. And I asked the question, does this involve going from the little self, the conditioned self, to the bigger self, the observational, connected, bigger self? And interestingly enough, education has been shown to decrease global brain connectivity because you're using the same circuits over and over and over again. So abnormal function connectivity of the DMN is associated with addiction, craving, and relapse. You have increased activity and decreased connectivity with the cortex, increased sense of self, and decreased executive function in addiction and associated with craving and relapse. So the DMN is that sense of self is engaged during withdrawal and preoccupation of the addiction cycle, within the addiction cycle, at the expense of executive control. Okay, so transcendent beyond the self, the little self, horizontal or vertical again, mindfulness, reference of relationship, your relationship, connection over trauma, connectivity over activity. It's a longer commitment for mindfulness, but it's more permanent. Psychedelics, set and setting, integration over experience, transcendent over altered. Shorter commitment, it's not as permanent as mindfulness approaches. And we all know that these are being combined in many ways, but they have to be done responsibly. So where does the transcendent self come in from the little self to the big self? So I wanted to touch on the older adults before I wrap up and addiction, that we are dealing with a massive influx of baby boomers who are using psychedelics, who are older and actually involved in quite a colored history. And we have other people that are starting to come into these roles. We have different health, political movements. We have all these things going on. And one thing that's inevitable is that a certain level of the population is going to age. You know, we have an increase in substance use disorder amongst the older adults, you know, as back 2018. Basically, you have an increase in SUD susceptibility, mood disorders, physical and mental impairment, chronic pain plays a huge role, and then you have medication misuse as well. As a result, alcohol is the most commonly common substance use disorder in those 65 and above, with 65% reporting high-risk drinking. So this is all from NIH. Also involved, you have marijuana, nicotine, benzodiazepines, and opiates. Risk factors for older adult substance use disorder is chronic pain, physical disabilities, immobility, living care transitions, loss of loved ones, forced retirement, poor health, chronic illness, high medication use, avoidance, coping, again, avoidance coming in, substance use disorder history, mental illness, and isolation. Isolation is a critical one. We're just getting past COVID, relatively speaking. So what is the treatment? Diagnose and management of chronic conditions, rebuild the support networks, improve medical access and case management, and evidence-based strategies. And as we all know, that one of the really salient things to keep an eye on is that the substance use disorder symptoms themselves can be confused with other chronic health conditions, such as natural age-related changes. So discernment and critical clinical analysis is important there. So addiction treatment needs to be biological, energetic, psychological, emotional, social, and cultural. And Carl Jung once said, behind every craving is a thirst for transcendence or wholeness. And I will summarize by saying that addiction is a doomed approach or attempt at experiencing sustainable bliss by supra-physiological, extreme, and unrealistic chasing of euphoria through drugs or substances. Sustainable bliss, the natural unconditioned state, can only be achieved through transcendence beyond boundaries and limitations and the conditioning into wholeness or connection and inner peace. And with that, you can contact me at solscience.org. Here's my email, my phone number, and I do have a YouTube video series on coaching and education, integrating different aspects there. I know it was a lot.
It was a lot, but it was amazing. So
Okay.
yeah, thank you so much. We do have some time for questions. So there were some in the chat.
Okay.
So the one that I just saw, if you can answer this. So how do you address substance use disorder-based permanent dementia in older adults? Do you have thoughts on that?
Oh, permanent dementia. Well, can I ask the person whether abstinence, have they tried abstinence? Or are they with the abstinence and the dementia?
So what it is a lot of my clients
Mhm.
will have alcohol-induced dementia
Okay.
or methamphetamine abuse or methamphetamine. And because they are the next generation to die, I work with people who are dying.
Okay. Well, thank you for your vocation, Alyssa, and your work.
Thank you. Thank you for your, I want to help the families
Yeah.
who are supporting their loved ones who are, alcoholics or substance use disorder,
Yeah.
people who have been affected either in the past or are still currently being affected because people are living longer
Yes.
with these disorders. So do you have any references or experience working with patients with permanent dementia caused by their substance use?
I don't personally have experience with that, but and discerning dementia from the substance is really difficult. And I've seen that with marijuana use disorder in younger populations. And so let's just go ahead and not separate them. Don't try to separate them. accept them as together, and then look at what the main mechanism could be. Oxidative stress, for example, it would be a good way to look at it. So you have oxidative stress in the brain that causes neurodegeneration. Free radicals. So one of the things that was interesting in graduate school, we were blessed with 3 great mentors. John Manch and David Baker at Marquette University actually developed Promentis company. I don't know if it's still up and running or not, but they were looking at something called N-acetylcysteine. It's an antioxidant called NAC, NAC, and it's a supplement and can minimize oxidative stress on neurons. But the one problem with that is it doesn't pass the blood-brain barrier very well. And so there, you can look for like prodrugs and things like that. But go ahead, Melissa, you have something to say about that?
Oh, just a lot of times this type of dementia is permanent.
Yeah.
Like the damage is already done. And so how do professionals in this industry manage that, treat that?
Well, if it's permanent, you're not going to go back and wave a magic wand, right? So you're looking at quality of life, prioritizing quality of life, minimizing damage, further damage. So abstinence, number 1, get them on something, try to make abstinence so that they are just with dementia, but not with the substance use disorder. So the hardest part is to keep them abstinent. Without abstinence, you don't have a starting point for any sort of dementia. And if it's irreparable or permanent, you only know until they're abstinent. So that's the easiest approach.
Yeah.
And then
Okay.
quality of life and increasing community reinforcement, structuring their life around abstinence over the substance, getting to the core of why they're still using it, accepting any sort of mental incapacities that have presented themselves, and allow for any sort of effective abstinent treatment interventions to show you what is permanent and what isn't permanent.
Right.
Dr. Blacktop, I've got an ethics question that you might be able to answer based on what you last said. Here in Oregon, at least, in order to be in a memory care facility that's licensed as memory care, you have to have dementia or Alzheimer's diagnosis. If you take those incremental steps to determine whether or not that alcohol-induced dementia will go away, then they lose their placement. And then trying to place somebody who was in memory care somewhere else on Medicaid in most cases, what's the ethics to doing what you're saying with the outcome not necessarily being in that client's long-term best interest?
That is a very confounding situation. And I'd have to ask, so when in those situations, I would say really go into your personal feeling in the situation based on the client, the situation, long-term. So then the other question is, use your judgment, your better judgment that's in alignment with you, Matthew. But really, what is more important? Abstinence from substance use disorder, abstinence from drug use and dementia, or living in a placement home. And those aren't mutually exclusive, right? So now you're dealing with a tricky situation where you're trying to do best for your client, and they're either going to be able to keep housing, or it clears up on their end. So I would have to say that would be on a client-specific basis to do whatever you need to do to use appropriate judgment to keep your licensure and confidence in your own integrity and morality as who you are, but also, evaluate the client at a specific individual level, and look at alternative options. Because for some people, if you're dealing with permanent dementia and substance use disorder, that's a different scenario, where if it's reversed, then what? So you first need to determine whether it's permanent or impermanent.
And I think those who work with dementia kind of understand that unlike Alzheimer's, you can actually see on a scan. Dementia, it's a position just like many of our mental health diagnoses that's over a 6-month or longer period of time making a medical judgment. We here in Oregon are very unique, I believe, in the fact that we have great dementia care, but in order to get into actual memory care, you have to have that actual physician-based diagnosis. And, I also recognize, because of working in the industry like I have before coming back to mental health, many of our dementia-based clients are not just in that level of care because of dementia, it's other activities of daily living that are going to be affected. So if we reverse that, it doesn't mean they necessarily can return to a home-like environment on their own, but then they lose the classification, or we're putting a physician in a position to certify their classification to uphold a housing first model and such. So I don't know. I don't know that I think you might agree the ethics of this may not be black and white, but it's
a pickle.
scary.
Yeah, it's a pickle because you're punishing people who become abstinent and don't have neurological disorders anymore, so we have to be advocates for rewarding those. We have to be advocates for facilitating a system that rewards those who are abstinent. And that may take some time.
Okay, are there any other questions from any people?
No, I would just like to say, Jordan, it's Claire here from Edinburgh in Scotland. That was brilliant, and it's, I'm across the pond. It's a universal problem that we have over here as well, and there's so much made sense, and I can't wait to watch it again. Thank you so much for putting that together. It was absolutely brilliant. Thank you.
Oh, thank you so much. It's an honor, and this is a passion and a vocation, and feel free to reach out. And the PowerPoints, Angela, should be freely available, as well as the recording. Is that correct? Eventually, the recording too?
Yes, it will.
Okay, good. And if there's any questions, feel free to contact me as well, and I appreciate that and the honor of being able to present.
Thank you. So for those who are in need of CEUs, we will be sending out an email as a follow-up, and just follow those instructions and we'll be able to get that to you. And I want to thank Dr. Jordan Blacktop for his time today. It really was great to see, these, I don't want to say innovative, because compassion and, being a presence for the people that we support is not a new thing, and it goes a lot farther than what we really think it does. So so thank you so much for everything that you've said, and thank you.
Thank you.